Good morning, good morning, good morning. Hi. So I recently read that Americans consume about 400 million cups of coffee each day. So we have a very small percentage in the back of that, and I want to be part of that 400 million cups a day. So feel free to go to your right through the doors, and there's coffee and breakfast with that. And while I'm talking about the doors to your left and to your right, the ladies' room can be found in the rear right, make a left, and the men's room to the back, left door, and make an immediate left. And so, again, good morning. I am Michelle Spencer. I am the Associate Director of the Bloomberg American Health Initiative, and it is my privilege and honor to welcome you to the School of Public Health and to the Obesity and Food Systems Symposium. And so, I'm happy to be here, and I'm a little bit out of breath, and I'm not sure why. So I'm gonna take a 2-second pause and just bring it down a little bit for myself. And for you too. So while I'm talking about some of the housekeeping, I would love for you to follow us on Twitter at American Health, and certainly subscribe and listen to us at the American Health Podcast. There's a few podcasts there that we would love for you to take a listen to and provide us some feedback. You have packets on your table this morning. In those packets are today's agenda, speakers' bios, as well as a notepad, an evaluation form, and flyers about the Bloomberg Fellowship Program. And when we're fully implemented, we'll have 50 MPH and 10 DRPH fellows each year. And those are full scholarships as well as some stipend support for our students. And so we know for the second year in a row, life expectancy in the US has declined. And so to help address this decline, Bloomberg Philanthropies gave a transformative gift to tackle 5 areas that are not traditionally seen as public health: addiction and overdose, adolescent health, violence, environmental challenges, and obesity and the food system. Rooted in communities across the country and through a 3-pronged approach of research, professorships, and education, this transformative gift allows us to train future public health leaders from community organizations, the private sector, and public agencies, to equip them with the research and public health tools to then go back into their communities and work with partner organizations to make immediate impacts. And that is a commitment that the organizations make for at least 1 year. We currently have 8 fellows. Mila Nigra, I saw her this morning. Oh, there you are, Mila. Mila is one of our current Bloomberg Fellow who focuses on obesity in the food system. Mila is a diabetes coach at the Institute for Family Health, the largest FQHC in New York City. And her work involves collaborating with providers and other staff to deliver services and programs that help patients manage their diabetes. Myself and the team, Okola, Faria, Dory, Fernanda are in the back, and we're more than happy to talk to you a little bit more in detail about this fellowship program. There's also flyers that we'll be distributing throughout the day, and so if you know change agents in your organizations, we want to know who you are, and we want to know who they are, because we certainly want to connect with each of you. And we know that, again, this transformative gift is not just here, but we're looking to really train the future leaders in public health in these 5 focus areas, and we need your help to do so. Now, we know that obesity is a significant problem in the US. You all know that. And we know that it impacts chronic diseases. We understand what access to nutritional and affordable food means. We know that there are community level, local, and state level approaches to addressing obesity. And we also know that there's a food system component to that as well. And so today we are here and challenged not just with having robust discussions, but challenged to be active, innovative participants. Each of you were invited here today with the express purpose of helping us to identify the research, the education, and the practice priorities that are relevant and impactful to addressing obesity and the food system. Today, we'll be informed by the experts, each of you, by the data and the evidence, which is key to the work that we do here, and the innovations. So thank you for being here. Thank you for honoring our invitation, and thank you for what you will contribute to us today. As we look forward to the day of promise and opportunities, we'll also be challenged with staying on time and keeping on time. And so there will be a timekeeper in the room. And so when you see that person, please do not ignore them. Please, please. But if you choose to ignore them, We have purchased a bright LED timer, and we have it in the back, right? And you will see it will go off, and it will make a buzzing sound, and we would hate to have to do that to you. So we'll use the first kind of passive way, and then we'll go a little bit more aggressive. So please don't ignore us. Before I introduce our focus leaders, I would like to recognize a few folks, some who are here and some who are not. Our Dean and Fearless Leader, Dr. Ellen McKinsey, who joined us for lunch or dinner last evening. Our Director of the Bloomberg American Health Initiative and Associate Dean of Practice and Training, Dr. Josh Sharfstein. And Dr. Al Summer, one of the biggest champions of the American, Dr. McKinsey, Dean McKinsey, as I just mentioned her. See, right on cue, I love it. Dr. Al Summer, who is one of the biggest champions of the American Health Initiative and Distinguished Professor of Epidemiology and International Health and previous Dean also of the School of Public Health. So I appreciate each of them, and certainly to our chair, Cynthia, thank you for being here as well. It is my great privilege, again, to introduce our faculty work group leaders for obesity and food systems, Ann Palmer and Wendy Bennett. Ann Palmer is the program director for the Johns Hopkins Center for a Livable Future and a senior research associate in the Department of Health, Behavior, and Society. Ann directs the Food Policy Network project, which seeks to improve the capacity of food policy councils and similar organizations to advance food system policies. Ann's research interests include food retail, food policy, food environment, obesity, urban agriculture, local and regional food systems, and community food security. Dr. Wendy Bennett is an associate professor of medicine at the Johns Hopkins University School of Medicine, the Division of General Internal Medicine, with joint appointments in the School of Public Health. Her research has focused on prevention and management of obesity and type 2 diabetes. Wendy recently co-led the systematic evidence review on methods of evaluating natural experiments in obesity that has informed the NIH Pathways to Prevention workshops. Please join me in welcoming Wendy and Ann Bennett.
Good morning, everybody. So I'm Ann Palmer.
I'm Wendy Bennett. Nice to see everybody here. Thank you.
So in 2007, about a year after I started the Center for a Livable Future, we hosted a seminar series on childhood obesity. And as a result of the series, we produced a 25-page report called Perspectives on Childhood Obesity, Recommendations from Public Health Research and Practice. The report covered a lot of the issues that we would cover today: food environments, built environment, neighborhood factors, schools, marketing, industry, public policy, the ethnicity gap, and cultural context. And Sharika was actually one of our speakers for that series. Last week, I read that report for the first time in 10 years, and I'm happy to report that, at least on paper, we've made progress in the last 10 years. Because nowhere in that report do we say the term food systems or systems science or systems approaches. But what we did do is have people who were interviewed to help, that had this sort of thinking going on already at the time. And so to put progress in perspective, I'm going to read a few quotes for you from the report. Increasingly, obesity is understood as a societal and environmental problem, rather than a purely individual or moral one. But researchers are still uncertain about which factors within the vast causal web are the most important and changeable. So this was in 2007, and over in the UK, they were already working on the four-site obesity system map, which, of course, it's the UK, so usually about a decade ahead of us. So that was launched that same year that we actually did this report. From Ben Caballero, we've tended to approach obesity prevention in the same as obesity treatment, restricting people's diets. For example, and in the real world, this doesn't work. There is no single approach for making a dent in the problem. So I don't think there's a researcher out there anymore who would say that there is a single approach, and if there is, I hope they wouldn't get funded. And then finally from Shariki, I think we health professionals who divide up the health problems to study them need to make sure we put everything back together as we go back into the population. All the changes that have happened in society that affect how people behave are part of an integrated system of how we live. And I think that integrated system is going to be a big part of our discussions today. So 10 years ago, when we were working on this report, I remember thinking it would be really cool if we could get a really great group of very smart people together in a room and have what I termed kind of an opinion conference. And just to start talking about how do we make progress in this field. And they wouldn't only just have to talk about their research findings, because so much of what we're exposed to, people we talk to, other research, our experiences inform our beliefs and our values and how we think this field should move forward. And so I didn't have that come true at that point, so I am taking this as my opportunity to have an opinion conference. So this is not just about sharing your research findings. I think it's much bigger than that. This is really about learning from each other, and I hope that today we have the opportunity to do that. And I want to thank you all for being here today.
So I wanted to get us started first with kind of an overview of the day, so everyone has your agenda. And I think we talked a little bit about some of the goals, but really ultimately the goals is that we're all participating here, we're talking with each other, meeting each other, and really ultimately gaining an understanding of ways we can move forward with interventions to improve the food systems to reduce obesity. So for that, I wanted to let you know a few things that you can help us with. So one is over lunch, we're going to have table topics so that people can sit together and talk about some of the issues that have come up from the morning. And we came up with some of these topics ourselves, but we'd really like everyone's input on what you're thinking about, what you're learning about in the morning. And so on the table are these index cards. So as ideas come up, write them down, and then during the morning break, we'll collect them, and we can collect them before lunch, and then we can gather together at some of these topic tables to have deeper discussions over lunch. The other thing that we're hoping comes out of this, and one of the products that will come out, is there's actually going to be a little paper that comes out describing some of our thoughts around obesity in the food system. And to help us with this paper, we would like you all to think with us about what are the most promising policies, programs, interventions, changes that we could make to improve the food system to impact obesity. And so we set up those sort of large Post-it papers on the wall. And so as you're mingling and walking around, just write down ideas up there, things that currently exist that you think are promising, but also brainstorms you might have for things in the future that we can promote. I also would like everybody to meet Mary Christ Irwin, if you want to stand up. So Mary is our moderator, facilitator for the day. Mary comes to us from Porter Novelli and is an expert in nutrition, and will bring a lot of her own expertise, but also help us kind of formulate and synthesize ideas. And so she'll be helping move the day along so that everybody stays on time, as Michelle suggested as well. So I want to get us started. Did I miss anything?
Just ask if Dean wants to say anything.
Oh, and Dean McKenzie, did you want to welcome? Okay.
No, I would like to welcome everybody and thank everybody, and I look forward to listening and learning, and wish you a success and a great day.
Thank you. Thanks for your support and for joining us. So let's get started, and I have the privilege to introduce our first speaker, Dr. Bill Dietz. Dr. Dietz, many of you know, he is a childhood obesity expert. He's a pediatrician. He currently serves as the chair of the Sumner M. Redstone Global Center for Prevention and Wellness at the Milken Institute School of Public Health at George Washington University, and he's the former director of the Division of Nutrition, Physical Activity, and Obesity in the Center for Disease Prevention and Health Promotion at the CDC. Prior to his appointment at the CDC, he was a professor of pediatrics at Tufts University School of Medicine and the director of clinical nutrition at the Floating Hospital of the New England Medical Center Hospitals. So I'd like to welcome Dr. Dietz. Let me make sure your slides are up. Where's
So when does my time start? I'm a little intimidated. Right
Are these yours?
Yeah, those are great.
Okay. There you
Great. Thank you, Wendy. It really is a great pleasure to be here. And the threat of the buzzer does intimidate me. And so I'm going to rush through the first series of slides, which have to do with changes in the prevalence of obesity by way of background, and then turn to the potential role that the food system plays. But I've noticed that I've said complex systems here, and I don't think that those systems are limited to the food supply system. But given the focus of this conference, I will not focus extensively on the physical activity side of this. This is from a paper that just came out in Lancet in the global issue. And we looked at the changes in the prevalence of obesity among U.S. adults by age, by ethnicity, and by gender. And as you can see here, these curves began to increase following 1971-75 and steadily increased up until quite recently. So it begs the question of what was going on. We know what was not going on was a cohort effect, that is, some intrauterine exposure because the entire population was affected. In addition, when we looked internationally at low and middle income countries and upper income countries, the curves were not identical to the US, but they were quite parallel in all of those settings, suggesting that some huge environmental exposure operating across the entire population was at the foot of this. We looked at some of these trends, and the dotted line here is the prevalence of obesity. But you can see that a variety of things change simultaneously: television, fast food, caloric consumption, miles traveled, caloric sweetener. It's not a productive exercise, really, to look at these, except to recognize that there was no single change that explained the epidemic, or more appropriately, the pandemic. So these are potential causes of origin. Those are factors which initiate the epidemic. But they are distinct from causes of course, that is, factors which affect the persistence of obesity. And we've begun to see changes with respect to the prevalence in the last decade or so. These are data that you've probably seen before from N. Haynes. The prevalence of obesity in adults has steadily increased without any kind of flattening, whereas the curves in 2 to 19-year-olds are flat, relatively flat, really beginning in 2003, 2004. And when we look more extensively or intensively at children and adolescents, there are very distinct differences. So I thought we were making progress in the 2 to 5-year-old age group because we saw a decrease in 2011-12 and followed by a modest but not significant increase in 2013-14, but most recently a big bump up in the 2 to 5-year-olds, which I mistrust. It's a small sample. This is a huge increase. We need to see more before we declare that we're not making progress. But there has been progress and a flattening of the epidemic in the 6 to 11-year-olds, whereas the adolescents have continued to increase. At the same time that this is going on, the prevalence of severe obesity in both adults and children continues to increase steadily. And I believe that this is an important subset. This is a group that's not going to respond to the kinds of changes in the food system that we're talking about. And it comes back to Wendy's comment about the difference between prevention and treatment. And I think we have to keep that distinction in mind because prevention is a public health initiative, treatment is a clinical initiative. I think you're also all familiar with the ethnic maldistribution of obesity. Interestingly enough, in children, the highest prevalence is now in Hispanic boys, followed in descending order by Hispanic girls and African American girls. The reasons for these disparities is poorly understood, and it gets more complicated when we begin to look at factors like socioeconomic status. So you can see that there is a modest gradient around socioeconomic status in non-Hispanic whites on the left and in Hispanics, but in the African American population, 2 to 19-year-olds, there is no gradient in terms of obesity by socioeconomic status. There is also no gradient by educational status, suggesting that this is a much more complicated problem and a deeply embedded one, and one which may reflect the very intense social and discriminatory factors which exist in this population. So that, for example, in DC, wards 7 and 8, predominantly African American, there are and mixed income, there are 3 grocery stores for 150,000 people. That's a huge inequity and reflects the kind of segregation, the residential segregation that exists in that city and existed here in Baltimore for many years and still persists. So we can't understand the effects of the food system independently of the population that's affected by it, and we'll come back to that briefly at the end of the talk. The other disturbing observation came in a New England Journal article from Steve Gortmaker and his group a couple of months ago, which looked at the predicted prevalence of obesity at age 35 years among children age 2 in 2016. I didn't understand for the longest time that this model underlies Steve's cost-effectiveness analyses. And I'm not going to dwell on that because, but it's worth noting that there are those cost-effectiveness studies that are based on modifications of this curve. But there are a couple of things to point out here. One is that the prevalence of obesity increases up until adolescence and then flattens, and then begins to increase again in young adulthood. And this is a pattern which is very consistent across ethnicities. So you can see that the curves in Hispanics and African Americans are comparable to those in the white population, but start at a higher level. In addition, in this paper, it was noted that the probability of obesity was dependent on baseline obesity status. So children who already had obesity at age 2 were much more likely to have a persistence of obesity, and children with severe obesity were about at a 95% chance of continuing obesity at age 35. So these, the other thing to mention is if we go back to this original figure, about 60% of children age 2 are likely to have obesity at age 35. So this is a real threat to our future. Now, the most recent observations that have concerned us is what's happening to the natural history of obesity across the population, across the lifespan. And you can see here, these are cross-sectional studies from N. Haynes, that the prevalence of obesity basically doubles from 2 to 5 years of age to 6 to 11 years of age. There's a modest increase in prevalence at 12 to 19-year-olds. It's about 21%. But there's a big bump up in young adulthood. 36% of adults, young adults, have obesity. This is 20 to 39 years old. And these are cross-sectional data, but they're buttressed by these data, these longitudinal data that Steve published, suggesting that there is this second increase, this second wave, and about 50% of adult obesity begins in young adulthood. And this is not a group that has been studied very intensively. In addition to the onset of obesity, this is also a high-risk period for the onset of severe obesity. These are data from 4 studies, beginning with N. Haynes 1, a 10-year follow-up, in which you can see there was already a disparity in the likelihood of excessive weight gain between men and women. Excessive weight gain in this study was defined as 5 BMI units over a 10-year period. The Cardia study used a different definition, 20 kilos of weight gain over this period, and you can see that the prevalence and the frequency of excessive weight gain increased with an emergent disparity between white and African Americans. But the most recent study, which was published in JAMA late last year, included the health professionals follow-up study and the nurses' health study, and you can see here that the prevalence of excessive weight gain, again defined as 20 kilos, in white men was 13%, in women was 22%. And that's about what we know. What's interesting is how little is known about excessive weight gain or the onset of obesity in this group. But the promise is that and I think one of the explanations of the disparities is between women and men is excessive weight gain during pregnancy or postpartum weight retention. And the promise is if we can prevent obesity in young adult women does that also mean that we can prevent obesity onset in their children? And that's a testable hypothesis. The other problem is that there are so many transitions during this period that it's important to begin to understand what accounts for the contribution to obesity and the onset of obesity and excessive weight gain. One notable candidate, which I think falls within the food supply, is alcohol consumption in young men, which is 170 calories a day in 20 to 39-year-olds, and 19% of all men, probably disproportionately among 20 to 39-year-olds. 19% of all men consume 300 calories or more a day of alcohol, mostly beer. So, but these other transitions, like childbearing, like getting married, like living autonomously, like getting divorced, getting depressed, all of these things may be contributing, and it's important to understand exactly what is contributing to this. Now, I want to turn now to the complexity of factors, and I wanted to begin with just a brief shout out to the importance of physical activity. This is an older study that looks at the changes in energy expenditure from 1960 to 2010, a 50-year period. And over that period, the mean decrease in daily energy expenditure among women, all women, not just employed and housewives, was about 250 calories a day. So that easily matches any of the kinds of shifts in the food supply as a potential cause of obesity. Now, it's important to note that physical activity doesn't play a significant role in weight loss. It changes the comorbidities associated with obesity, but it's not a strategy for weight loss, but it has to be a strategy for prevention. And there have been multiple contributions to why physical activity is decreased, including the increased use of appliances, physical education, recess, suburbanization. You can see that here. And I was curious about exactly what was going on 50 years ago, so I interviewed my mother-in-law, who turned 100 on January 28th, and her day was busy, and it was full of housework. It was making the beds, making breakfast, doing the laundry. No, they didn't have a dishwasher, washing the dishes, drying the dishes, hanging out the laundry. All of those things were moderate levels of physical activity, which I think can contribute to that significantly to that 250 calorie difference. But turning now to diet, I think many of you may have seen this slide, which is what an average family of 4 consumed in the 1950s. And in fact, this was the photograph of the century, according to some judge. I'm not quite sure. But notice the absence of processed food here. The only processed food here that I could spot is the cornflakes that are in the upper left-hand corner. Now, contrast that, and while I think that reflects a very simple food system in which there were relatively few intermediaries between production on the farm and consumption by these families. But since then, the food system has become considerably more complex. And what's happened is that the food supply has become increasingly industrialized. And the kind of farm to consumer has largely disappeared because of the multiple intermediaries that now exist in terms of processing, transporting, et cetera. And there have been a variety, I think, of contributors to increased food and beverage consumption, which are shown here. All elements of the current food system, like marketing, cost, the portion size processed foods, variety, availability, all of these have been shown to be associated with increased food intake. And it's important that not to just look at these, but as the day will progress, I think we're going to be looking at what the deeper drivers of these are, and we'll come back to that in just a minute. And there are some data, rare, but some data, which look at the changes in dietary habits and weight change. And these are, this is from the Nurses' Health and Health Professionals study, and it's important in this study to note that this is a change analysis. So this is a change in consumption versus change in weight. And notice that on the upper part of this, the consumption of unprocessed meats, processed meats, sugar drinks, French fries, potato chips, are associated with increased rates of weight gain over this 12 to 20-year follow-up, whereas the consumption of whole grains, vegetables, and fruits are associated with either weight maintenance or modest weight loss. So the other point I'd like to make, and I think it's going to be echoed later today, is that I would argue that we don't have a food system. We have multiple food systems, and different products have different determinants. So I wanted to just walk you through one of these, which I think is a significant contributor to obesity, and that is sugary drink intake. So the mean caloric intake from sugary drinks in the highest quartile, the highest 25% of 12 to 19-year-olds, is enormous. You can see in Mexican Americans, it's about, and among men, young adult men, it's almost 600 calories. And that's pretty true across all of these SES groups, or all of these ethnic groups. And there is a SES disparity in the consumption of these drinks. So it begs the question, why? What's driving this consumption? Well, the consumption is first of all that you can get a lot of soda for a very low price. And this soda is actively marketed in all sorts of venues, and particularly on sports venues, which is the purview and what young adult men are largely watching. But this, in turn, is driven by production, the production of corn and the consumption or the conversion to high fructose corn syrup, which in turn is supported by subsidies from the federal government. So when we think about strategies to alter the consumption of sugar drinks, we come up with a variety of strategies, like excise taxes, which are now in place in at least 7 cities. Labeling in hospitals. The Boston Hospital Commission instituted a sugar drink labeling in all their hospital cafeterias. Hopkins is a leader in this, by the way. I think that you reduced the availability of sugar drinks in your hospitals and clinics about 2 years ago, so that they now only constitute about 20% of the drinks available. Choice architecture, which has been employed by some of the Boston hospitals, putting the red labeled drinks in an inaccessible place or not visible as you walk into the cafeteria. Food labeling and public health campaigns like those in New York City. So with all these efforts, why aren't we more successful in making progress? Well, one of the challenges is policy resistance. And there are 2 forms of policy resistance. One is what Steve Gortmaker has called the fat industries, the food, advertising, and television industries. And we learned this firsthand in the working group, the interagency working group on food marketing to children, that these groups came out of the woodwork to push against the standards that we had put in place for food marketing to children. But the other thing that we can't neglect is that there's also consumer demand, that when excise taxes have been introduced or when these campaigns have been introduced in New York City, the pushback has been from consumers who want their drinks, who want their big gulps at low price. And so there are these 2 sources of resistance that really have to be bridged if we're going to be successful. The other thing that I wanted to just mention, and Shariki may talk a little bit about this when she's up, is that as we think about ways to modify the food system, particularly those particularly the food system accessible to low-income or other ethnic populations, there are a variety of strategies that move from increasing healthy options to reducing deterrence to healthy behaviors, to building community capacity and improving social and economic resources. So on increasing healthy options, we can think about food retail and the provision of these foods, or improvements in diets in schools and work sites, or changes in the built environment which allow the building of supermarkets. At the same time that we're reducing the promotion of unhealthy products or reducing the costs of healthier foods. And I recognize that underlying these are very significant determinants that will need to be navigated. But I think this moves us from thinking about the consumer as the source of this problem to more of the environment as the source of this problem. And finally, I think that we also need to think about the food system in terms of these other targets for obesity control. So firstly, reducing energy intake is obviously a high priority, but how do we, since we know that energy density and volume are what determine intake of calories, how do we reduce caloric intake by maintaining the same volume of food and decreasing the caloric density of those foods so that regulatory systems which rely on volume persist? Other periods we've mentioned, pregnancy, breastfeeding, I think deservedly as part of the food system, particularly for infants. And sleep and resilience to adverse childhood experiences. We know that adverse childhood experiences are an important cause of severe obesity in adulthood. I don't think we know very much about the identification of those experiences and more importantly, how to build resilience among children exposed to those experiences. I think that the strategy there comes back to Shariki's framework, which is to build community resilience, that parents in communities where their children are exposed to adverse childhood experiences, in order for those parents to be resilient, they need to live in a resilient community, which in turn emphasizes the importance of working on the upstream determinants of health. So I hope I've given you an overview, first of obesity and then an introduction to the food system and some of the factors which are at play. And I'm looking forward to a more detailed discussion later and amplification of many of these themes. So thank you. I think we have time for questions, do we? Okay, good. Yes.
So on the facts slide, I noticed a picture of Washington.
Right.
And just wanted to get your thoughts on that.
Yes, I neglected to mention that the lobbying efforts directed at Capitol Hill and legislation are what maintain the subsidies that keep high fructose corn syrup cheap. So that's where that's it. And it's really this Capitol Hill is shown here, the Capitol is shown here, but this could equally be the city council in Des Moines, Iowa, or any other type of governance, which would be the target to resist regulatory initiatives, like a local tax.
Other questions?
Tamar.
I guess one of the things I struggle with is that I think everybody agrees that this is a really complex problem, and you've outlined some of the things, and probably not even all of the things that contribute to obesity. And the question when we leave the room is, okay, well, where do we start? And if you had to pick one or two or three interventions that you think would be most effective at fixing this problem, what would they be?
So which problem do you want me to fix? Do you want me to fix obesity or the prevention of obesity? Because the answers are much different.
Right. Let's go with prevention.
Okay. So I think physical activity, particularly in schools where we have children as an option, and we're trying to navigate this in DC. It's a complicated problem to reintroduce physical education. But when we started this work in DC, the recommendation for physical activity in pre-K kids was 20 minutes a day. 20 minutes a day for a full day. And we managed to get that changed to a floor of 60 with a max of 90. So physical activity starts there. We're working on, in the same way that Hopkins began to clean out the sugar drinks in their hospitals, we're doing the same in DC through the Hospital Association. I think that sends a message about, in the same way that when hospitals went tobacco-free and stopped selling tobacco and physicians stopped smoking, it changed the conversation, it changed the norms. So these are not immediate returns, and I don't think we can expect immediate returns. But those are two examples, one on the physical activity side and one on the food side, that I think we need to consider. Neither of those alone is going to make a difference. But we've got to promote a culture of not just wellness, but physical activity and better nutrition. I should also say, I think that the work that, and full disclosure, I'm on the board of the Partnership for a Healthier America, that the commitments that have been made by companies to change the food supply have worked and are held accountable. And again, those are long-term outcomes, but I think in combination and with other initiatives, those are the things that we ought to be pursuing.
Hi, Bill.
Hi, Margot.
I'm big on changing the whole food system, and down the line, I would like to change all of it to support healthy eating and to not undermine healthy eating. But as somebody who works in that first little box of
That's the biggest box, isn't it?
trying to change policy, it's rare that you can change everything all at once. So I guess maybe just like to the room, if you're thinking about direct pressure on a company, oftentimes you have to agree to stepwise change. You know, if you look at McDonald's, for example, they shrunk the fries and added apple slices, and then they got rid of soda off the menu, and they just adopted nutrition standards. That my experience has been that we have been much more successful when we work with companies one step at a time. In DC and in state and local with state and local policy, also my experience has been, if you went in with a comprehensive obesity systems bill that had 12 policies, all of which by themselves would be very difficult to pass, trying to pass them all at once, I don't think would be possible. So we might want to plot and plan among ourselves of what our vision will be for changing the whole food system, but when we think about like what's the first thing you would do, it's probably going to be one sub-bullet here and another sub-bullet there.
Right. So I think the strategy, I mean, again, Margot, you're talking about changing the food system. I think we can only change the food system one food at a time. And your example of McDonald's, I think, fits that notion.
Terrific presentation, Bill, and I'm going to ask you for your slide set like I asked Kelly for his about 25 years ago when he presented. So this is a terrific lead up to the problem in the U.S., but this is a global phenomenon, as you know well. Do you think it's roughly the same factors, just in different strengths around the world, whether it's a developing country with, half the population, the wealthy population is obese and the poor population is skinny, or France or all these other places. I mean, there's so much variation underlying, but in fact, this obesity epidemic is global.
Yeah, I don't think we know enough about the international pattern yet, although Lindsay Jakes at the Harvard School of Public Health has an analysis underway based on the Lancet publication last year showing the changes in prevalence of obesity by region. It was both obesity, which was increasing, and undernutrition, which was decreasing. She's begun to analyze what was going on on a country-specific basis in terms of urbanization, dietary use, car use, and maybe that will provide some insight. The most difficult challenge internationally, I think, is that in middle-income countries, 10% of children now have obesity and are stunted. And that poses a real challenge for care. I mean, how do you address obesity and undernutrition and chronic undernutrition in the same children? And I don't think we have good models for that either. The final point to be made, particularly about low and middle income countries, is their care systems, their health systems, are poorly equipped to deal with this tsunami of obesity that they're facing with diabetes right behind it. And I think that what we've begun to think is that focus on diabetes may be more, give us more leverage in terms of health system changes, and that could then be based or could then argue for preventive systems in low and middle income countries.
We have time for one more question. Anyone? Okay, then. Thank you so much, Bill. That was terrific. And for moving forward, I need everyone to introduce themselves as they're asking a question. We're recording this, and it will greatly help those who are transcribing.
Okay. Okay, so moving right along, thank you, Dr. Dietz, that was great. So our next session is shifting gears a little bit, and we're gonna think about how a systems framework can inform public health approaches to obesity and the food system. And I'm gonna introduce Kate and Ross, and why don't you, I think it might be good to come up and sit, maybe at this first table right here. So Kate Clancy, there you are, Kate, is a food systems consultant and a visiting scholar here at Hopkins for the Center for a Livable Future. And she has conducted interdisciplinary research and teaching for the last 5 decades. She writes a column for the Journal of Agriculture, Food Systems, and Community Development on the application of systems concepts to food systems research and practice. And Ross Hammond focuses on the application of techniques from complex systems science to population health and disease prevention. He is the director of the Center on Social Dynamics and Policy and a senior fellow in economic studies at the Brookings Institution. He has academic appointments as well at the Harvard School of Public Health and the Santa Fe Institute, and he serves on the Food and Nutrition Board of the National Academies of Science, on the Lancet Commission on Obesity, and has advisory roles at both the NIH and FDA. So, Kate, do you want to start us off? Okay. Do you have your slides loaded, right?
Yes, he said they were there.
This mouse is really hard to use.
Looking for the clock. Where's the clock?
There. Okay.
Hello, everyone, and sorry for the raspy voice. I'll do what I can here. My task this morning is to review some of the basics of what we wanted to talk about throughout the day. Among all of you in the room, there are quite different levels of knowledge and experience with food systems and with systems approaches to obesity. So what I'm going to do is present a brief review of what I've found in some of the very extensive literature, huge literature, published over about the last 20 years, as to why systems thinking makes so much sense in understanding research and actions on the obesity problem. So I will start with food systems. This is the food systems figure from the Institute of Medicine 2015 report, A Framework for Assessing Effects of the Food System in the United States. Any food system is the aggregate of food-related activities and the environments, political, social, economic, and natural, and more, within which these activities occur. Notice the supply chain here is encompassed on one side by food demand and food services, by food and food services going in one direction, at the same time that things like finance and capital and demand information are moving around the same nodes on the figure. Within each of the circles, there are multiple examples of structures and behaviors that affect each other and end users in multiple ways. And I always want to point out how important here, again, capital is, labor and trade, certainly the environment, which could use a lot more space on this model. Anyway, over time, so that's kind of the food systems definition that we want to be working from today. And over time, as the phrase food systems has come into the food discourse, I've noticed a lot of confusion and a lot of misunderstandings, and a few of those are listed here. And I'm just going to spend a moment on each of them to say that, for example, food supply chains are not food systems, although it is astounding how often you will read that that's what they are. Food supply chains are a part of most food systems, or maybe all, but they don't define the food system. And if we forget that, we forget all kinds of things about the variables that are going to affect obesity. There are multitudes of food systems, as Bill just said. There are uncountable, the number of food systems there are. It depends on where one is situated and what food issue is being addressed. The third one is mistaking actual food systems for aspirational ones. That occurs all the time, not just among nonprofits and activists, but all kinds of people. And what this translates into is unrealistic visions of the future and makes improvements difficult to plan and to reach. The fourth one I've got here is confusing traditional work on food issues with work on food systems. This translates into, and you'll see this everywhere, very abstract, kind of generic understandings of the real problems in a particular food system, and a lack of clarity as to what questions to ask, what are the most salient intervention points, et cetera, et cetera. So I'm hoping that today we can be conscientious about how we use the term food system and be more specific in identifying which food system and which parts of food systems we're talking about when that's going to be relevant. It was about 20 years ago that the concept of food systems themselves was embraced as an analytical tool. Before that, except for economists, the term food systems had not been used very much in terms of a way to address the world and look and see across multiple sectors. The best of that food research that started about 20 years ago, that research on food systems, used systems science and systems thinking, but not all of it did, and certainly not all of it does now. Hence the title of my talk, The Convergence of Food Systems and Systems Thinking. There are many areas in food and agriculture where systems science and approaches are being utilized. Obesity is first on this list because it's the focus of our gathering today. The others are listed in a loose chronological order as to when the focus on systems science started inside of that sector. Obviously, agroecology became big time in the 1960s. Farming systems in the 1970s and going ahead. Food security, actually about 20 years ago as well. Food science and materials, I think the industry has always used some kind of systems thinking around the development of new materials, and food scientists are coming into that more recently. And then for me, in terms of food and agriculture sectors, transportation is one of the more recent ones, and there's some just great work going on about transportation within the food system, within a systems framework. So as part of the review this morning, I thought I should list some of the key elements of complex systems and food environments. So and I'm not going to talk about all of them, and some of them will come up in a moment. One of them is heterogeneity. Obviously, the causes and consequences of obesity vary widely across people, populations, food environments, all kinds of other things. And even any small community of people is very heterogeneous and exposed to different things in different ways. So heterogeneity is a concept that is central to thinking about systems approaches. Another one here is nonlinear. Most systems are nonlinear. If they weren't, the world would look quite different. Nonlinear means a relationship between elements in which the cause does not produce a proportional effect, or as Ross often points out, a small change in something may have a very large effect, and you can't predict that. Another piece of a complex system is our boundaries. You can't research, and I'm only going to define boundaries in one way right now. You can't research or intervene with everything at the same time. You need to choose the boundaries of a project carefully. Now, people say that in different ways, but it all means the same thing, that you want to bring a systems lens to anything that you're doing, but you do have to set the boundaries for your research, and you have to think about what that should look like. So the next set of things I want to go through is I wouldn't say it's cursory, but a review of a large part of the literature that's come out around obesity over the last 20 years, and ask one question first and then ask another set of questions in a minute. Why has a systems lens been applied to obesity? First of all, obesity can be seen as an emergent property, which means it's not a property of any specific element, but of multiple elements, just like on Bill's slides, and can't be reduced to any one of its lower level characteristics. Okay, so if you're going to think about, so obesity emerges out of all the things that are on the list that we just looked at. And we wouldn't point to one thing and say, that's it. This is the reason that the Foresight Project, which again appeared in 2007, said in one of its thousands of graphs, it feels like thousands of graphs, said adopt a whole systems approach to obesity. And the major pieces there are the following: deploy and integrate as many interventions as possible, improve collaborations across multiple organizational boundaries, target interventions across the whole course of life, set clear long-term societal goals. Changes are required across many different policy areas. So those seem pretty straightforward, but if any of you know the Foresight process and the graphs there, every one of these has between 10 and 100 pieces that go deeper and deeper and deeper into what that means and how any one of those might be accomplished. So it's very hard to look at the big map, but it's really useful to use what they've come up with. The next step is why has a systems lens been applied to obesity? Obesity, you've often heard this, is a wicked problem that can't be solved by a single or isolated intervention. This reduced Foresight map, which is in the work that Diane Feingood and her colleagues have done, shows the major elements from the larger Foresight map, and the thickness of the lines around these categories up here represents the number of variables that are interacting with each other. In some case, physiology, in the end, most of the variables that are related to obesity are interacting with physiology in some way. And so this is also another way to take a look at the complexity of this issue and what happens when you start applying a systems lens to it. Since, excuse me, excuse me. So some more reasons. Most of the variables affecting obesity are interdependent. That's pretty obvious. That's obvious to see from these maps. Most are dynamic. They're changing over time. People are changing over time. Most of the causes or contributors to obesity are changing over time. And that means that we have to have methods of capturing those kinds of changes. And the variables occur across all scales. Literally, as Shriki has said, from genes to global climate change, all of which are related to, in some way, the food system. And I liked this quote that I read: systems methods are tools that incorporate rather than control for the complexity of the problem. And that's a big shift in how a lot of researchers think. And so I think it's really important to keep that in mind, and knowing eventually what kinds of tools are that can do that is really important to move towards finding some better answers. Obesity shapes and reflects a range of other issues. So because of that, we can understand why it's important that systems models can replicate the real world to better understand the structural complexity of what we're dealing with. Now, they can't get super close, but they certainly can replicate the real world much better than a lot of the reductionist research that has so far tried to grapple with obesity. And then, not surprisingly, systems approaches require more logical and comprehensive thinking. And that means that a whole lot of different people have to be at the table. Multiple disciplines have to be at the table. We need both interdisciplinary and transdisciplinary research. Even multiple disciplinary research doesn't get us as far as we need to anymore. So then, as that is occurring, and stakeholders from everywhere, including in communities, are involved, systems thinking encourages a rethinking of organizations and not just systems issues. And I think you can, if you sit down, if you're sitting there with an idea of a community working on this problem, with people from all kinds of places in the community, from clinicians to community activists concerned about children's health, you can see that once more things start getting out of the table, you have a whole different thought process going on among people about what's important and maybe is not so important, et cetera. And then finally, almost there, at a more functional level, a systems lens is applied to change methods and language, to set the right goals, focus on how actions are conceptualized. And there's a quote from Dana Meadows: "The true goals for a system are not necessarily what the actors say the goals are." I think a lot of us make that mistake. The true goals are deduced by observing the system in action at as many levels as you can. And of course, it's not just that you deduce the goals, but the best part is, while you're doing that, you deduce the objectives and the strategies, and sometimes even the tactics, in terms of how you're going about addressing the obesity issue. So the final two in the package here of why do you apply a systems lens to obesity is to help move analyses from causes of the problem to a solution orientation. And it's pretty clear that people in this room and many other places would be ready to try and expend more energy on looking at what solutions might be in a useful way. And then finally, systems are a metaphor for understanding and communicating about complex phenomena. We want to reach solution stages more quickly. We want to be able to explain to different stakeholders in a cogent way the complexity of obesity, but also how different worldviews affect their thinking and decision-making, and in the end, when policies are being debated, where compromise might be possible, by having a much deeper understanding of where in a system, in the food system or any other system, the variables come together, or at the nodes or at what we call leverage points, to make us feel that we can get some movement on this. So very quickly here, systems approaches can provide new insights, more reality, more tools, solutions that may be more sustainable. Sustainable because there's a wider variety of stakeholders engaged and a wider knowledge of the problem as it exists in the real world. Systems approaches can do these things: anticipate unintended consequences, make predictions, target intervention points more readily. Excuse me. And I'm going to make a point here that through all the readings, many people were saying, you know, systems approaches are not magic bullets either, but they're complementary to and important to be in a toolbox of how you think about obesity and how you approach it, both at the level of research and at the level of interventions. Systems approaches help to close the gap between research and practice. And certainly that's the case much more if you're doing transdisciplinary research, which involves people at the community level, along with a lot of other researchers. They can help develop visions of alternative solutions. And the one that I find myself using all the time, systems approaches help to put counterintuitive findings into a context. And there are so many counterintuitive findings across all of the research that all of us do, not just in obesity, and they come up and we kind of sit there and scratch our heads. If you use a systems approach, it's much more likely that you'll be able to say, oh, I know where that came from. That's because those two things are interacting that we didn't think about before. So there's a very rich literature here and many compelling reasons to engage systems approaches. So why aren't there more projects utilizing these approaches? And experts are making these recommendations. And these are just some of the recommendations, again, that came out of the reading that I've been doing in the last month or so. We need more clear practical guidance, training, and technical assistance for researchers, for people who work with them on the ground, for students, for postdocs, for the whole array of people who don't have much background in using systems approaches. The suggestion is made that there be partnerships and mentorships set up with experienced systems researchers in universities and other places to kind of speed the process along. We need a lot more work on how to measure systems variables like complexity and feedback. And I think, in my own experience, that that's one of the major reasons holding back a lot of the work. Ross is going to talk about a lot of measures, but whether people are ready to learn them and figure out how to apply them is something else. We need tons more data because if we're going to use models, and Ross will talk about this, we need data to build models on, and we don't have a lot of the data that would be necessary to do this kind of work. And then we need studies of accountability and replicability, just evaluations of everything that's already going on, at least to a level that those evaluations can help improve what other people are doing. So I've tried to really quickly put together where the convergence of food systems and systems research and thinking might be occurring and needs to occur a lot more. And that's it.
So I've had the pleasure of working closely with many of the other speakers today, including Bill and Kate, who went before me, and Chris and Shariki, who are coming next. And you'll see lots of connections in my talk with all these others. Bill focused on sort of unpacking obesity, Kate on food systems, as well as obesity. And I'm going to try to unpack this third piece of system science a little bit for you and help you understand some of the different forms and flavors it takes, particularly at this intersection with obesity and with food systems. And I should mention quickly, as you heard in my introduction, that I have a number of advisory appointments, but I think it's important to put up front that nothing I say should be construed as the opinion of any of these groups, only my own. And I'm going to start by very briefly just recapping why we're using system science in obesity increasingly. I think Kate did a great job talking about that, so I'll go pretty quickly through that. I'm going to try to talk about what we mean when we say system science and give you a bit of a typology for parsing this rapidly growing field. I'm going to show you, as time permits, 3 diverse examples spanning obesity in the food system of system science in action in one form or another. And then I hope it will tee up a really good discussion that we'll have with both Kate and I and all of you. So you heard that obesity is complex. Both Bill and Kate touched on that, in which behaviors and outcomes are affected by the interaction of many different factors across multiple scales, with many different actors, many different contexts, and lots of feedback. And all of these things are challenges for interpretation, analysis, and policymaking. I'm not going to belabor this point because I think both the previous speakers spoke to it very nicely. And this has led to lots of interest in public health to address complexity, not just in obesity, but in many areas of population and public health. There's been now 5 different Institute of Medicine, National Academy of Medicine reports, pretty much one a year, calling for systems perspectives, complex systems tools to address all of this complexity. But what do we really mean when we talk about system science? And if you look at the obesity literature, you've seen a movement from think pieces about why we should do systems approaches to obesity to a lot of pretty detailed work on etiology to a much more recent focus on solutions orientation and policy. And when people say this word system science, they actually, I'm going to argue, mean one of three things. And the first of these things is what I'm going to call a systems approach. This is not a methodology necessarily. This is a way of viewing the world and a way of approaching policymaking, for example, or solutions, in which you focus on the whole picture to understand the role that context plays, to understand the interaction of the many different factors, to, in the case of public health, look beyond the traditional arena of health to think about determinants well outside those conventional boundaries, to think about the importance of circumstances and context, and to focus on leverage points. And there's a lot of systems approach work that doesn't necessarily use formal methodologies from complex systems, but that is nonetheless very systems in flavor and very important. The second thing on my list is qualitative complex systems tools, of which there are many. An example is systems mapping, which you've seen some examples of already, and you'll see some more later today, that manages complexity of information by visualizing and organizing it, often in a participatory way, to identify where the feedback loops and interconnections are, where some synergies that might be leveraged are, and where some key gaps might be that can be filled to accelerate progress. And the third thing people might mean when they say system science is a set of pretty specific quantitative complex systems tools, which are mostly computational or mathematical models. And these operationalize information we have from data, from literature, from theory, into a testable quantitative substrate in which we can explore mechanisms, dynamics. We can think about policies in a virtual world before we try them in the real world, to help understand their potential unintended consequences, their distributional consequences, and we can, in some ways, help pinpoint what data is needed more specifically. And so these are three very different things that people mean when they say system science. It all gets kind of lumped together in a lot of the discussion, but I think it's important to keep them separated. And I'm going to suggest a rather crude 3x3 typology that I just sort of put together for this audience, for this context. I couldn't figure out how to reduce it to a 2x2, so it's a little messy, a 3x3. And I think it's important when you're thinking about this huge space that we're talking about the rest of today and tomorrow, to think about which of these boxes we're really talking about. So the columns here are the three things I just said: the systems approaches, the qualitative complex systems tools, and the quantitative complex systems tools. And some of the work is about obesity, which may involve food systems, but may also involve many other things. And it's about etiology. Some of it's about obesity prevention solutions. It may also involve the food system, but it may not. And some of the work is about food systems, which may treat obesity as an important outcome, but may look at many other outcomes, including climate change, land use, food safety, labor and equity, nutrient deficiency, et cetera, et cetera. And so I think there are very few things that are doing all of this at once. And so it's important, I think, to bring clarity to the conversation. So my examples I'm going to place on this as I go. And the first example I want to talk about is the Institute of Medicine Accelerating Progress on Obesity report, which came out in 2010. Both Chris and Shariki, who are speaking later, were on that committee, and I had a consulting role with that committee that took an explicit systems approach to considering strategies for obesity prevention, and that used a qualitative complex systems tool, systems mapping, to actually help shape the recommendations that went into the report. And so what they did is they took a long list of potential strategies and recommendations that look like this. This is what a normal IOM report looks like. And they turned them into a map in which each recommendation and strategy was color-coded by which sectors were involved in that action, and they were connected by evidence to show where the synergy was. And the committee actually explicitly considered synergy between packages of recommendations is one of the criteria for what is the strongest possible recommendation the committee could make to accelerate progress beyond what had already been tried. And they use this method, among others, to do that. And so what do I mean when I say synergy? There's some specific concrete examples that I think are useful to consider in our discussion today. So for example, there's an idea of prerequisites for success. So if you're considering menu and food labeling, you might also need to think about nutrition education. If you put calories on labels but no one knows what a calorie is, the labels aren't going to do much. So that's a prerequisite, those two different policies that are connected that way. If you invest in parks and recreation infrastructure to improve physical activity, and you also reduce crime, improve transportation and supervision options, then many more people might actually use the park and recreation infrastructure. So those two things are connected. Similarly, if you invest in park and rec infrastructure and you improve healthy food options nearby, then you have reinforcing feedback between those two things, which can be mutually beneficial. If you do advertising reform with education to improve media literacy, similarly, or if you do advertising reform with investment in parks and recreation, then you can remove barriers to physical activity that reduce screen time and thus exposure to advertising. So again, there's positive synergy. So I won't go through, there's many of these. So this is an example of, I would argue, systems approach and a specific qualitative complex systems tool, systems mapping. And it was primarily about obesity prevention solutions. And some of those solutions did involve the food system, but not exclusively. And I would argue that the central message of this report is that you have to focus on the whole of the system, that you can't just focus on one subsystem. This vision of doing coordinated, multifaceted prevention interventions that are sustainable, that are effective, has been around now for 8 years or more. And we haven't necessarily achieved that many exemplars. And it's actually because this is quite hard to execute in reality to do. And the challenges include coordinating policy and action across many different sectors, agencies, actors, the need for scientific interdisciplinarity. The process of implementation itself is complex, that knowing what to change is not enough. We need to know how to change it effectively and sustainably. And there's huge heterogeneity across settings in which we might want to try to do these interventions, which can mean that the same intervention doesn't work equally well across all these different contexts. So I want to talk for a second about a paper that Chris and I wrote this last year that lays out a vision for how we are actually going to move past this impasse of knowing what we need to do but not being sure how to do it. And it starts with this idea of a systems approach that was highlighted in the APOP report and in the foresight diagram and many other places, with a focus on childhood obesity prevention. But it also introduces this idea that we really need to focus on the community level as the sweet spot for effective change. And why is that? That's because this is a high enough level of scale that we can change macro level variables like the built environment, population exposures, the retail food system that we know are playing a role and that are hard to do one at a time in a clinic. But it's a low enough level of scale that we actually have a chance at successfully coordinating across education and transportation and retail and all these different sectors in a way that's just very hard to do at higher levels of scale. The third point here is that we need to figure out in a rigorous and scientific way how to tailor general evidence-based strategies to specific contexts, to understand what are the features of those contexts that matter, and how do we take a general strategy that's worked somewhere else and tailor it to fit to that context. And there's an idea that's organizing a lot of the work I'm doing right now that's called precision prevention, which is an idea that just like we talk about precision medicine being about customized treatments to individuals, we can think about our prevention interventions also being precise, meaning that they're tailored, in this case not necessarily to individuals but to groups or settings. But we can use many of the same approaches that have had great success in, say, cancer treatment, and many of the same methods in the context of social and behavioral science and community obesity prevention. That's my argument. I'm happy to talk more about that. And the fourth point in this paper is that new methods may hold the key to how we actually do this, specific quantitative methods that have been used to good effect in other fields facing similar problems but are still quite new in this field. Which brings me to my second example, which is a study that Chris and I are co-PIs on that's called COMPACT, Childhood Obesity Modeling for Prevention and Community Transformation. That's actually a partnership between Brookings and Tufts, but also Harvard, Washington University in St. Louis, Deakin in Australia, and Auckland University in New Zealand. And this study is trying to, and has been successful to a certain extent, in developing a general theory of how public health intervention, particularly obesity prevention implementation, occurs in communities, and has determined what aspects of community structure and setting might be most important, or at least among the most important, in shaping intervention success and how to effectively measure them. What is the right data to collect to actually assess that? And in developing models that are quantitative and testable that allow us to do this tailoring of intervention strategies of a whole community system's nature to specific contexts. So this project is called COMPACT. Chris is going to talk more about it. It did start with qualitative tools, the kind of systems mapping you've seen before, and I won't go through the details of this because I think Chris is going to in her talk. And what we've done in this project is to take a general conceptual theory coming from qualitative methods and literature and other experiences, put it into a quantitative model, apply that testable model to data sets from real world situations, improve the model, and iterate. And by iterating a number of times through that loop, we can design very sophisticated packages to help us answer how to tailor this approach to any particular real world setting that we might want to consider, not just in the US, but internationally. So this is a project that's about obesity prevention solutions, but that's really about the qualitative and quantitative tools and what they can do. Some of the focus is on food systems in the qualitative piece, but the quantitative tools actually do not focus primarily on the food system, although it's involved. In the background, they're much more upstream than that in ways Chris will talk about. The third thing I want to briefly touch in on before I get the hook here is efforts to integrate a more central food system focus. Efforts to take complex systems tools, apply them to a food system, and have obesity as one of the outcomes of interest. So this is the inverse of what I've mostly been talking about. And I'm going to start by talking about the Lancet series on obesity and the Lancet 2 series in particular, for which I co-authored a number of papers. And this one in particular is about smart food policies for obesity prevention. And so this is really about food systems and food policies, but it takes individual behavior as a central focus in obesity and tries to understand how different choices about food policy and food exposure will shape different preferences and outcomes for individuals in their choices in that food environment over time. I don't want to go through the whole paper in detail, but there's quite a bit of qualitative work that went into it. I have 5 minutes, okay? And I want to stress, though, that even this paper, which is really about food systems up front, with obesity as an outcome, does, among its key points, say that how quickly food policies work and how effective they are will vary depending on context and heterogeneity, and that a combination of actions is needed to support effective, mutually reinforcing, and systemic change. So these are the same themes you saw in earlier work being echoed here. And this work is an example of these two boxes using a lot of quantitative tools that aren't necessarily talked about in great detail in the paper, but are there in the background. You saw this food system report mentioned a number of times, so I'm not gonna talk about it anymore. You've heard about it. It's a great resource. I was on that committee, as was Kate, and that really was focused front and center on the food system, with many outcomes, obesity being one of them, and used qualitative as well as systems approaches, and did discuss some quantitative tools. And I want to just briefly mention the Lancet Commission on Obesity that Bill is helping to run. Where's Bill? I was surprised Bill didn't mention this in his talk, but the Lancet Commission is actually taking an explicit systems approach to not only the problem of obesity, but also the problem of undernutrition and the problem of climate change, and how those systems are actually deeply interconnected. And it's doing it at a very high level, and it is using systems tools, both qualitative and in some fairly focused ways, quantitative tools. I don't have any visuals to show you because the work of that commission has not concluded, but stay tuned for more on that. So I think I'll stop there. I'll leave up on the screen while we're having our discussion a nice quote from the food system report arguing, as Kate stressed, also for the need for training in this space as a central part of the way forward. Thanks. Yeah. Do you want us to go here? Okay.
Okay, wow, my head is spinning, although it doesn't take much to create that particular action. Thank you for having me here, Ann and Wendy, really appreciate it. Knowing just a couple things, knowing we're going to have limited time for questions, the organizers have tried to create enough time and ample time, but I have a feeling there are going to be tremendous amount of questions based on the rigor of the presentations today. Please write down questions you didn't get a chance to answer so we can accommodate those. And no, this is yours. This is a room of intellectual heft, the likes of which I haven't seen in a while, and we have to use it, make it work hard so we can wring every drop out of this and learn as much as we can. And as Tamar said last night during dinner for the talk, for those of you who missed it, basically she was saying, this is not strum my guitar about kumbaya. It's about really thinking about things, and disagreement is fine, and raising hard points and really getting into some gritty discussions. We don't have to all be in violent agreement, but we have to move forward. So press it, enjoy it, and now we're going to open this up for questions for Drs. Clancy and Ross, and the mics are being taken around the room. Please state your name and your affiliation for the record on this so we can use it in the recording. First question, Shariki?
Because I'm closest to the person with the mic. Thank you. That was a great presentation. And I have one question from the experience of that committee, the Food System Framework Committee. I had a brief interaction with that committee at one of the workshops. And it was very clear that if you start from the perspective that the food system is more important than health, because society would collapse and there wouldn't be anybody in it to be healthy, you get a different take on a lot of the issues. And so I wonder if that value, how health is valued, and how the food system and the economy and the job, the whole thing that is the food system, did that come up, and how would you reconcile food system versus health, system that produces health?
I mean, I think you're right that committee considered, its remit was to consider multiple outcomes that flow from the food system, and those include health outcomes, not just obesity, but also undernutrition, nutrient deficiency, et cetera, but also economic outcomes, social outcomes, and environmental outcomes, actually. And what the committee quickly discovered was that all these things were pulling you in very different directions, and that there were almost always trade-offs involved, and that if you did things to promote health, you were likely going to incur costs elsewhere, in economic costs, social costs, or environmental costs, and vice versa. And I think there is a chapter in that report that argues that the design, such as there is one, of the current U.S. food system at the national level is actually to promote a health goal. It's just a health goal that we don't have anymore. But the health goal that it was designed to address was the possibility of widespread famine in the U.S. following the Dust Bowl era, and to create lots of plentiful and of widely available calories. And it did a great job at that. It's just not our goal anymore.
With the obvious policies that still exist to support that. I mean, the kind of stuff that both Margot and Bill mentioned. I also think that, yes, we never had that direct conversation. Are we ever trading off food and health in the 18 months that we worked together? But I think that we always kept coming back to seeing, everything was interrelated, and that on the health end, there were lots of things that had to be done, like Ross just said. And if you looked at some of the things that in the report about what needs to be done to make the issues that agriculture is causing for the environment, if we improve some of those, we also improve health, and not obesity per se, but health. So that I think that's where we were. Sriki.
Next question.
Thank you. Just wondering, are there any studies done on the effects of drugs? You know, how, drugs, people take drugs and then those drugs, really cause them to gain weight.
I'm sure there are empirical studies about that and maybe clinical trials. I'm not aware of any of the kinds of systems modeling that we were talking about today that's specifically about that. There is quite a lot of work, and I wrote a paper that touched on this, but that's about the connection between infectious disease and obesity and undernutrition, respectively. And the links between infection and nutrition are very deep. Both biologically and from a solutions perspective. But drugs per se, I'm not aware of work in that area.
I have a question, and I was interested that your last slide really got us thinking about training opportunities. And I'm curious, we're here in a school of public health. We strive to train people to do public health better, to do research, practical public health in the community. Whether you have thoughts on what we need to train people. So is it that we need to learn the methods? Is it that we need to learn how to do, develop these partnerships, and whether there's models out there that would enhance our ability to collaborate with each other? But even to start with, our basics like MPH programs. So what can we do to train people?
Many things, and this is a shameless plug, but I've been working with 4 or 5 universities around the country just in the last year based on a project that Ann and I have been knee-deep in for 7 years now, a systems project, about talking about how to do successful, very large interdisciplinary projects. There's a great literature on it. There's a lot of teaching materials. And so I definitely think that's one of the starts. There's a big difference between, as I mentioned, between multi and inter and transdisciplinary research. People should know the differences, and then I'll start with that, and then Russell.
Yeah, so I've also been doing a lot of teaching, even though I'm not at a teaching institution, because there's a huge unmet need in this space, as I'm sure you're aware. And even though system science and complex systems approaches have been added to the core competencies for accreditation for public health, there's still a dearth of actual curriculum out there. I actually am a co-holder of an NIH grant that's trying to fix that problem, and I teach same course in different versions at Harvard and at Michigan, and I've taught it at NIH as well. And the way I think about it is that what we really need is 3 different kinds of trainings. One is people who are conversant in these approaches and these tools, who can read an article and understand what it's saying, and who can serve productively on review committees. We need a pretty large body of those. The second group are people who are going to incorporate these approaches into their research, but not as the primary practitioner, but as part of a team, where they're perhaps the domain expert or driving the questions, and they're working with a practitioner. And that's a slightly smaller group, but also pretty sizable. And then the third group are people who actually have the technical skills to do the quantitative modeling, and you don't need a huge number of those, and it takes a lot more than a couple courses to enter that space. But I think about those 3 categories as a useful way to frame what I'm doing.
And I would just add one quick thing to that, how important it is for your first category to do that because of the dearth of people who are fully ready to be on review committees, especially at the Department of Agriculture. I think more are available for NIH, but not at USDA.
And if I had my way, the first exposure to that first group would actually happen at least in undergrad, if not earlier, not waiting till graduate school is hard.
And I think we have time for one more question. Is there? There we go.
Good morning. Thank you. I wanted to ask you, I want to come back to Shariki's point with regard to the food system. I'm David Page. I'm a part of Hopkins. How would you address the tension that exists within USDA, which is a promoter of the general food system, regarding commodity support versus good nutrition advice in terms of the various conflicting information that comes out, increasing cheese production and pizza versus commodity support and good health recommendations?
Well, we've had to deal with that for decades now, at least since the 70s, when it became really obvious what the problems were. There's a lot of complexity there. Tamar and I've written in my column, and Tamar has written about the issues of whether or not the subsidies do, in fact, have any kind of direct effect on health. There's a lot of literature that suggests they don't, because the whole issue is much more complicated than what some people have put out. I think that I think that we could say that it would be great that if, even working at the local level, and I agree that at this point in time politically, the community level seems to be more promising around some of these issues for multiple reasons, and including politics. But I think, and all the work that everybody has been doing for years to make that better, to do all the kinds of education, deserve a systems approach of their own. It would be very difficult to do that. But I think that if we could pay more attention to where the leverage points are in the nodes where federal and local and state policy intersect with other pieces of the food environment or other organizations or the food industry or whatever, that could be helpful.
And we kind of glossed over this in the interest of time, but in that food system report, there's not only sort of a lot of background and a lot of detail about resources that are out there, but there's actually a pretty specific methodology, a framework that people can follow to apply as a number of steps that you're supposed to follow and considerations at each step to actually do this kind of analysis for any question. And we actually briefed several different parts of USDA on this report and passed along that approach to them. And I think there was a fair amount of interest at one point in time. I haven't kept touch with how that's gone since then.
Okay, we do have time for a couple more questions because we can compress the break, and I don't want to stop this conversation, and there's a microphone right over there.
Okay, and hopefully this is a quick question. I'm Angela Odoms-Young. I'm at University of Illinois at Chicago. This question is actually for Ross. I know you talked about the community level, and I know that there can be like 100 definitions of community. Some of that is actually socially constructed versus geographically constructed. And I was curious to learn more, particularly in your study or other work that you've done, in looking at communities. How are you defining community? And then the second part of that, because there can be smaller neighborhoods within communities, is how are you looking at risk? So the community may vary. You may have some people of color, people with disabilities that may be at higher risk. How do you include those factors in the systems thinking?
Well, I could give a whole talk just on an answer to your question, but let me try to be super brief. I think I'll take the second part first. The equity considerations and the distributional considerations of anything are paramount, and actually complex systems approaches really lend themselves to that because they don't force you to aggregate.
Oh, and I guess my question is more of the social, because you have to have the person in it.
Right, so a lot of the models I do are individual level models, so the people are there, they're explicitly represented, and all different kinds of heterogeneity across those people can be represented and doesn't have to be collapsed or ignored, which is why I like these approaches in part. But to take the first part of your question, I think in my mind, both the social definition of what a community is and for obesity prevention, the physical definition are important because of these built environment elements that we keep stressing as part of the puzzle. And I think there is a sort of a scale, a wide range of scales at which you can think about communities. I've done work that I would consider community-oriented in as large a place as a city, like New York City, and as small a place as a very small town in rural Australia. And lots of things in between. So I don't have a clear, succinct answer for you to that.
Okay. Additional questions? One more. Who's got it? There we have one. Need a mic.
So I have a question about...
Can we have your name, please? Your name? And you need a microphone?
Sorry.
Yes.
Lee Bone. I'm at the Bloomberg School of Public Health. And I have a question about how this model, this obesity systems approach, can be applied or said the other way, how the tobacco approaches and their models of system approaches can be applied to obesity?
So I do a lot of work in tobacco as well, using many of the same methods. There are some similarities. There are also really important differences. I would say that the tobacco field is also a field that is just very recently moving to really use quantitative complex systems models just in the last 5 years. And there was actually an IOM report commissioned by the FDA to study the use of agent-based models. The whole report is about agent-based models and tobacco policy, and that just came out 2 years ago. So it's really sort of happening now, and NIH has been funding a number of centers in this area. I think a lot of the focus in tobacco control at present is about the retail environment, because that's been proven a path of minimal resistance legally compared to many other pathways that might be considered. And so where we're talking about the food system and we're talking about the retail environment for food, there's a lot of parallels to how we talk about the retail environment for tobacco, I think, and the exposure people have to advertising and to the availability of products. But I think the obesity space is much broader than that in its consideration, and I'm not aware of any evidence that a very single-focused policy like that for obesity can work in quite the same way that it does for tobacco. So that's a brief stab at that. There's a deep issue. We could talk about it for a long time.
Thank you so much. Can we get a round of applause for this fabulous panel? Okay, and next up is Wendy.
Thank you, Ross and Kate. That was a great discussion. I want to remind everybody to, if you have questions or you think there are topics that you'd like to discuss over lunch, to fill them out on your index card. We're going to collect index cards at the break, which is right after this next session. So I actually have been taking some notes on my index card, so hopefully people can pass those over in a little bit. And so we're going to move right along, and our next session is on the state of the evidence and innovations targeting food systems to reduce obesity. And I would like to introduce our speakers for that session. So our first speaker is Dr. Christina Economos, and she is a professor and the New Balance Chair in Childhood Nutrition at the Friedman School of Nutrition Science and Policy and Medical School at Tufts University. She's also the co-founder and director of Child Obesity 180. And this is a unique organization, and it brings together leaders from diverse disciplines to generate urgency and find solutions for childhood obesity prevention. Her work focuses on improving behavior, policy, and environmental change to reduce obesity and improve children's health. And I'm also going to introduce Martin Bloom, who is new to Johns Hopkins. He became the director of the Johns Hopkins Center for a Livable Future in December. He previously was living in Italy, and he was recruited here from the UN, from the World Food Program, at the World Food Programs as the global coordinator for the World Food Program at the UN. And so why don't, Chris, why don't you start? Come on up, and then Martin, you can come up after. And then we'll have time for discussion when you're both done. And let me get your slides. And this should work as well.
Okay, great. Thank you. Good morning, everyone. It's nice to be here. This is a really great meeting. I'm looking forward to the discussion as we move through the day. This is an area I've been trying to work in for about a decade, and I was charged today to talk about the state of the evidence and innovations targeting food systems / food environments to reduce obesity. Ross set me up really well. We've been working together on different projects throughout the years, and I'm really an interventionist. So I'm going to bring this down to a level of working in communities and trying to apply some of the systems approaches, systems thinking, and most importantly, the methodologies at the community level to create change. So if you think about Ross's 3x3, I really work in that middle row and all the way across. And I'm going to start by just sharing the way I've been thinking about this for the past few years, and that is that we really have to shatter silos and ask the right questions. And I appreciated the discussion at dinner last night that Tamar led around really asking the right questions and disagreeing when we need to. I think to move forward, particularly 8 years after that APOP report that Ross referenced that I was part of, where we really laid out a framework and a roadmap for us to move forward at the national level to address obesity prevention using a systems approach. Why aren't we doing that? It's incredibly expensive. It requires a lot of interdisciplinary and transdisciplinary work, and it takes a lot of time. What we're doing here today and into tomorrow for some of us is really important. We don't often get the time to do that. Our funding mechanisms are quite siloed. We tend to work on a single problem with a single solution. And as Bill showed at the beginning of the day, I'm not sure that's getting us where we need to go. So I think we need to shatter silos and take a systems perspective. As has been noted, it recognizes interdependence and interconnectedness and interactive relationships between individuals and their environment. And I'm going to talk today at the beginning about what I found in the literature, which are often single environment approaches. I'm not criticizing those. I've done them myself. Our funding mechanisms are set up for ASCIT to test a hypothesis, an elegant hypothesis that's often addressing a single problem in a single sector. It gets messy when you bring in a lot of variables, and without the methods that Ross described, where we can handle the complexity in the analysis and the modeling, it's risky to do that work. You often won't get funded for it. So what we see are single environment studies. And lastly, I'm going to really end with understanding what we do differs from understanding how we do it. I think we know what to do. We've seen a lot of reports. There have been a tremendous number of think pieces. We have a pretty good sense of what the food environment looks like, what the problems and challenges are, and how we need to move forward and really turn the tide on obesity and the other health consequences that we've observed. But I don't think we've done a good job understanding how to do it. And what I'll talk about at the end is, in collaboration with Ross and others, we're applying some systems methods that I think are helping us understand how to do this work better. And that is that the processes, dynamics, and the connections really matter. And the last question, I think, or one of the last questions asked about working at the community level is really where I've spent most of my career. So let's start first with what to do. So you may be familiar with the Nourishing Framework. This is an excellent framework that lays out for both the food environment and the food system how we need to work with respect to different policies and examples of policy actions. This is by the World Cancer Research Fund, and it's been cited in many other publications, including the most recent Lancet Commission. So we have a good sense. We have a list. Where do we need to work? What are the policies we need to address? Which ones target the food environment, and which ones really harness the food supply chain and actions across sectors to ensure coherence with health. And that's really the comprehensive food system as Kate laid out for us. We also can look to the Foresight map, which is a decade old, that again looks comprehensively at the causes of obesity, the determinants. And we know that two of these areas within the map comprehensively really define the food system for us. And if you look within that, there are dozens of little boxes. And again, we often see studies targeting one of those boxes, not all of those boxes together. So we have a good sense, we have frameworks in the literature, we have lists of areas that we need to address, and we have a pretty good sense of what to do. And so let me just move through, excuse me. I don't know if this is doing what I wanted, just give me a second, sorry. Maybe not, it's okay. So this is a review by Karen Glantz looking at retail grocery store marketing strategies and obesity, and dozens of papers that have looked at strategies to work at the grocery environment and to give us an understanding of whether we alter price or information or access and availability with nutrition information. Do we get an effect on what people buy? Do we get an effect on what people eat? And many of these studies have shown success if they're well-designed, and it tells us that in fact, if we go to the retail environment and we put a lot of money into it, we can make a small change in what people purchase and how they consume. Will it reduce obesity? Highly unlikely. Will it make a dent in someone's behavior? Maybe. An updated review that was just published in BMC Public Health, and I apologize, this was animated, so this was supposed to pop on at the end, but the point is the same. This is an updated review that shows you exactly the same thing. So we know we can make progress if we work at the retail environment. Okay, so something's happening with my animations when I use this. Can I just do a different way so that my animations show up? Just the key. Nope. Okay, it's okay. I'm just going to go with it. We've all given talks where things have happened, right? I gave one, the best story is at Chautauqua. Has anyone ever given a talk there? There were about 5,000 people in the audience, and I worked for weeks on my slides. And when I arrived, the woman said, "Why are you bringing your laptop?" And I said, "Well, so we can set my slides up." And she said, "You're not using slides." That was my in the moment, okay, I can do this without slides for 5,000 people, so I can handle the animation problem here. Hopefully it won't get worse as we move on. So this is another review of the dietary impact of introducing new retailers, so bringing grocery stores, farmers markets, mobile markets into a space where it didn't exist before, and looking into whether folks in the community purchase and consume more fruits and vegetables. A systematic review, and what do we find? There's evidence of increased fruit and vegetable consumption, and it's most consistent among adults who began shopping at a new retailer. So this is availability, accessibility, bringing it to the space. We can make a dent in behavior. Now, this is an individual study that was just published where they used double up food bucks. So for SNAP participants, if they spend money on fruits and vegetables and they're given double up food bucks, they can double what they're spending on fruits and vegetables. And what we see from this single sector, single behavior study is if you go into a waiting room where low-income patients are and you incentivize the use of the double up food bucks, you see an increase in fruit and vegetable consumption at 3 months and even up to 6 months later. So positive. And then here's another one that was just published looking at marketing strategies to encourage rural residents of high obesity counties to buy fruits and vegetables in grocery stores using recipes, where they instructed them to buy the fruits and vegetables so they could make the recipes and to increase their fruit and vegetable consumption. And you can see here that the recipe cards influence fruit and vegetable purchased in general. So these are important. Again, they're single sector, likely to make a dent in behavior. So that really tells us overall with frameworks what we should do, a list of things. It shows us that if we employ some of them in a single setting, that we can get a little bit of a bump in behavior, but it really doesn't tell us how we do it comprehensively using a systems approach. So I'm going to talk about a study I did a decade ago that was originally designed to put together a portfolio of evidence-based strategies, bring them into a community, and impact childhood obesity prevention. And so we worked in the community of Somerville with 2 socio-demographically matched controls, and we brought in a lot of strategies that at the time had a good evidence base behind them to work in multiple microsystems within a community. So we worked within the home, the government, healthcare, media, school, the community at large, which included restaurants, ethnic groups, after-school programs, and what did we see? Whole community approach where we employed multiple things, as I mentioned, and here were the results. So we saw a decrease in BMIC score, obesity prevalence in children, there was a parent spillover effect, a decrease in sugary drink intake, screen time, and increases in many things, including additional farmers markets and gardens. And so this was really the first time when these results were published in 2000 through 2010 to show a comprehensive approach at the community level that decreased obesity prevalence in children by employing a package of evidence-based strategies. Now, what was interesting is at the time when we received this grant, we weren't really set up to use a systems approach. It wasn't until after the study was over and the foresight map came out and I realized what we had done was incredibly complex, that it really had been a systems approach. And so one thing we can rely on when we work at the community level and we take this kind of comprehensive approach is things are often sustained. And so what I show you here is reports that have been put out by the community of Somerville showing a decade of progress, because everyone who was involved over a decade ago is still involved now, and most importantly, policies have been sustained. So that work on the ground, involving the community, putting a comprehensive approach in place with a portfolio of strategies resulted in sustained progress. They published a 15-year report as well, which just came out about a year ago. And then the mayor of Somerville went on to speak at the White House and really be a spokesperson. So this is a really nice success story. But when it was done, I realized it really was a systems approach. So retrospectively, using qualitative mapping as Ross described, we went back and really tried to visualize what had happened during that period of 3 to 4 years when we were working in Somerville. And so working collaboratively with a systems scientist, this is really what happened. It was a dynamic process. It wasn't a list of things. It was very interactive, very interconnected with lots of feedback loops. Some of them happened quickly, some of them happened slowly. And you can see on the right, the food environment was a really important part of making change in obesity at the community level. What I also want to emphasize is that food environment, in order to impact the individual, which you see at the top, operates through many other microsystems in the community. So you don't just change the food environment and expect it to impact an individual. It has to operate through other organizations and structures within the community to actually have impact on the individual level. So Ross mentioned Compact, which is an NIH grant we've been working on. And what I'm really interested in as part of this project and collaborating with Ross, who has the quantitative skills and the modeling capacity, is to understand and leverage existing systems within a community to implement an upstream approach to obesity prevention. So what do I mean by that? What we all care about is health at the individual level. That's very downstream. And we know that to reach everyone in the country and the world, it's going to take upstream approaches. And that's why many of us focus on policy. But I'll go back to the what. We know what to do. We know what policies we want to reverse. We know what kind of engineering we need to do to transform the food supply and the landscape. But it's really the how. And I would argue that we need upstream approaches that focus on the how. And that's what a big part of Compact has actually focused on. So we're working on a concept called stakeholder-driven diffusion, which is the importance of people working upstream to ensure mid and downstream change. Much of what we're doing today, where a collection of people exchanging ideas, you could call this an upstream approach, where we are, for the most part, not out in Baltimore helping people eat better. We're thinking about how we would do that. We're thinking about a framework, a way that we want to work moving forward. We're doing that at the community level. Every community in this country has some sort of coalition. Many are focused on obesity, many are focused on food systems. So we're working upstream with coalitions, using system science to change and monitor their knowledge, their engagement, and their networks, with the hope that midstream changes occur within organizations in terms of structure, environment, engagement, and then downstream impacts are realized with respect to behavior and change in health and biology. So how are we doing that? These constructs we're working with are knowledge, engagement, and networks. And simply defined, knowledge is the understanding of community-wide efforts to prevent obesity. This is underpinned with multiple domains and multiple questions that we're assessing. Engagement is the desire and ability that individuals have to translate their knowledge into effective action. And networks, as many of you know, are closeness, influence, and frequency of interaction with other folks in the network. So the way that we've engaged the community is through a systems methodology called group model building. And this is our collaboration with WashU and now Boston College, where folks in the community are taught to think in a systems way. And group model building is really defined as a participatory research method grounded in systems dynamics, where you're able to help individuals externalize mental models and develop visual representations of complex systems to better understand them. We're all sitting here with a mental model about food systems, about what we need to do. If we got up and started to draw and interact, I bet we'd create something pretty special, pretty unique. We need community folks to do that. If we expect them to take a list of comprehensive and complex recommendations, we need to give them a roadmap to do that, and that roadmap has to be community specific. As was pointed out before, there's culture, structure, historical context in communities, and we need them to become part of the solution, and we need them to live the sifting and sorting of what needs to be done in their own community. So this is one of many things we did with a particular coalition over the course of 2 years to engage them in the process. This is what their map looked like when we were done. So it started out drawing, and then using a systems tool, we actually developed a dynamic map for them to see how complex their own community was and how things needed to work together comprehensively to create synergistic effects. And then this just shows you just one representation of their own network, with the committee members in black and their alters in red. So you can see things can diffuse if you influence a smaller group who has the ability to impact a much larger group. So in that project, we're working with group model building, social network analysis, and agent-based modeling. So to our knowledge, it's one of the first, notwithstanding the Baltimore work, which I know will be spoken about later, which is why I didn't mention it, one of the first whole-of-community approaches that's using not just systems thinking and systems approaches and systems mapping, but quantitative complex modeling. So I'll leave you with a slide that I think we need to think about as we catalyze food systems change in communities. We need whole-of-community approaches, and that includes a whole body of literature on community assets and leveraging them, capacity building and engagement. They all have their own tools and methods to do that. Group model building is one. We need a group of people in a community who are willing to make that change, who are willing to listen to experts, to work with them, and to do the work on the ground. We need coordination connections between sectors and levels using the methodologies that have been described today. We need purposeful, sustainable, and evidence-based strategies. So the what that I described, I think we have that. And now we need to really work on the how. We need to blend in innovation from the private sector. They're ahead of us in many ways. They can take a product and get it to market quickly. Why can't we take all of our knowledge and employ it quicker? We need a lot of communication work, and I'll sort of position this as marketing techniques, campaigns, and brands, pricing strategies, economic incentives, and cost-effectiveness models, and lastly, rigorous design, quantitative and qualitative evaluation procedures. Thank you very much. Thank you for your patience with that snafu.
Oh, sorry. Okay, so I'm very happy to be here after 3 months at Hopkins and dealing with a lot of different problems than I did over the past, I would say, 20, 30 years. But even at this meeting, I have the task to present something what's happening at the global level, and much more from a very, I would say, political perspective, how things have changed in the past 5 years dealing with the issue of obesity. It's this one, no? So we have, since a couple of years now, a global nutrition report, and actually that's the first time when we have a report which deals with the whole world, and not only with undernutrition, but also with overnutrition. And if you look at what we have at the moment, we have billions of people who are actually micronutrient deficient, like 2 billion about. We have a lot of kids who are still stunted. We have acute malnutrition. We deal with adult obesity, but also we have an issue with overweight. So you can see that we have multiple problems from a nutrition perspective. And it's not for nothing that the SDGs who were in place a couple of years ago had actually have a goal to have no nutritional problems anymore by, I think, 2025. But what actually is good is that we have a lot of data. And I think Bill already was referring to a Lancet paper which came out in 2017, dealing with all the problems of both undernutrition as overnutrition, but particularly looking into kids between 5 and 19 years. And I will give you some of the data looking at that. But again, actually, the nutrition report, which actually be written, partly written by somebody here at Hopkins who's now working for FAO, Jess Fanso. So if you look at the prevalence of moderate and severe underweight in kids between 5 and 19 years old, you can see it's still prevalent, particularly in Africa. Looking at Asia, India is quite dramatic if you look at boys, for example. Indonesia, Southeast Asia. So the problem of undernutrition is not gone. And this is not the typical stunting, which is actually measured in kids between up to 5 years of age. So this is just undernutrition in a different population. But if you look at overnutrition, you can see that, in fact, a lot of places who actually have undernutrition as a problem has also overnutrition. So it's not anymore that we can focus in lower middle income countries only on undernutrition. We definitely have to focus on both, which gives a lot of new challenges to both the Minister of Agriculture as well as the Minister of Health, for example. This slide shows you the trends over a period of 40 years, which is very interesting because what you see here is that the purple is severe undernutrition, then you have moderate undernutrition in blue, you have normal in green, and you see overnutrition and obesity in red and orange. And what you can see is there's definitely an increase in obesity levels both in boys and girls and overnutrition over a period of 40 years. But not, despite the fact there is a decline in undernutrition, it's still very high. So we're dealing with a very complex problem. And if you think about that, I worked in nutrition for quite a long time. We never dealt with overnutrition. And if you look at overnutrition came in the international arena to NCDs, not actually through nutrition. It now is embraced by nutritionists, but you can see that all expertise in the world is much more focusing on undernutrition. So we don't know how to deal with it. And if you look at the Lancet series, for example, the Lancet series on undernutrition is a completely different group as the Lancet series on overnutrition. So that tells you something about a fragmentation, and when we have a system approach, even the people who are dealing with the problem are quite different. So this slide, hopefully it works as animation, so shows you what happens since 1975 and I think 2016. I hope they have to push the button. No, oh gosh.
So what I did is I just used the keyboard, not the button, and that worked.
Okay, you can see the size.
We need more technical assistance here. Lunch will be served at that.
So what you see here is that the size of the bubble is the number of individuals, and of course on the side is also the increase of the prevalence of obesity. And you can see it's quite dramatic what happens in the last 40 years. And you see that, yes, the US is growing, but China, for example, which is yellow, is quite enormous. And countries like Mexico, who had not a big problem, are also quite substantial at the moment. So this is an important slide to give the perspective of what's going on in the world. The Lancet series in 2015 had actually one important conclusion, that nothing had changed. There's no country who actually can deal with the problem. And it's an important observation, because quite often we say, okay, we know what to do, but in fact, if you know what to do, but the world doesn't know what to do with it. And it's an important step, because if you understand that there's an issue, then actually maybe you can tackle it. So what are the main reasons for it? So I think, the Lancet series came up with certain things. They said, okay, what are the beliefs of understanding what obesity means? That's actually framed in a very simplistic way. People believe in they act in simple dichotomies. And, there's always a strong opinion. It's, for example, the sugar. Important factor, but is it the only factor? So what they came up with is that a lot of discussions are always between personal versus collective responsibilities. The supply chain versus, in fact, the individual, responsibility. Government regulations versus self-regulation by the industry. Top-down versus bottom-up, community-based versus actually having real policies. And treatment versus prevention priorities. And again, what I said before, a focus on undernutrition versus overnutrition. And you can see that this doesn't help. Again, we have heard so many people talking about already the system approach, and it's necessary to include all these different, points of view, which are maybe contradicting and are actually, there are different people actually have an interest in it, but you have to embrace that when you want to solve the problem. And it's not for nothing that, in fact, the world, if you look at WHO, has focused on system approaches since the past, I would say, seven years or so. So from a health perspective, what's happening in Geneva, they already start to accept that, but particularly actually the NCDs, not so much the nutrition world. And it's only since I think the last ICN2, which is 3 years ago, when also Rome-based agencies start to embrace this complex idea of accepting the fact that you need to think in systems. So, and of course, you have seen this slide over and over, but it's interesting that the international community has accepted this concept based on what happened here in the US. But of course, they adapted this concept in a little bit more, which is applicable to what's happening in the rest of the world. So what they said is, in fact, they can distinguish about 5 different food systems based on what the percentage of agriculture contributes to the GDP. So you have an industrial system, you have a mixed, transitioning, emerging, and rural. And what I did is, in fact, I took the paper from 2017 on over and undernutrition, and I looked into the various food systems. And so, for example, the rural system is, very much in South Asia. And then you look at the emerging, it's more Southeast Asia. You look at transitioning, it's Latin America. Then you take the Northwestern, because Germany, for example, is a good example, in Holland as a mixed food system. And then you have more the English-speaking system, like the US, for example, as the industrial form. And what's really interesting, if you look at this combination of both, then you can see that the rural food system approach has quite high levels of undernutrition, both severe as well as moderate, but already has a little bit of overnutrition and obesity. And you can see that it's interesting if you compare, for example, Southern Latin America with Northwestern Europe. Despite the fact that the level of overweight and obesity is about the same in both continents, the level of undernutrition is very different. So you can see that it's very important to realize that there are different models, because if Southeast Asia and Southeast Asia will have the same trend, what kind of trend is possible? They will go to the trend of Northwestern Europe, or will they take, in fact, the system of Southern Latin America? And I think it's important to have some lessons learned from each other. And this is why I think it's important when we think about the future that the US gives so much lessons to the rest of the world, but even the US can learn some of the lessons which are happening in the rest of the world too. So already I think Christine showed this, and just a couple of slides to show what are the food environment strategies. And I took one strategy based on what Josh asked me to do. He said, can you look into the issue of sugar tax? And that's very interesting. Again, in 2017, there was an analysis looking into 13 different places where they had the sugar tax. And they are very different. It's very complicated to put them in one box because there are, different ways they deal with it. But if you look at the results, it's very interesting. Most of the impact on obesity, there was some impact on obesity based on the sugar tax. But what's more interesting is how they dealt with the fiscal needs. So some countries were using it directly for income. Some were saying, okay, the extra revenues will use for health purposes, for public health purposes. So you can see that sugar tax as a phenomenon is so much more complex. You have to think about what are we going to do with it. And it's really interesting to see that we are just at the beginning of understanding that how we have to deal with one, actually, what people consider as one particular strategy. Again, if you take this into Indonesia, or you take it in, for example, South Asia, or you take it in Africa, or you take it in the US, it's very different, what the implications are. One of the conclusions also of the report is that you need to have a high sugar tax because the price elasticity is quite low. So, for example, for the poorer populations, in fact, it has a bigger impact than for the middle class. But if you deal, of course, with Southeast Asia or you deal with Africa, again, the impact can be much bigger when you deal with an increased tax intake. So again, we need much more research to understand this and get better data to have one particular conclusion about it, saying, oh, this is good or this is bad. It's not at all like that. It's the context where you do your research, how important these strategies is. And so I'm very worried when I hear, of course, we have the Lancet Commission, which is always fantastic, but to have, in principle, one paper and come up with really good recommendations for the world is very complex. It's not easy to do, so big task. One thing I also would like to say before, this is interesting too, because there's also a recent paper looking into other benefits. So beyond, in fact, obesity, and they looked at productivity. And of course, it's modeling. This is not a paper which has results. But it's interesting to see that if you, they did some analysis in Australia, and they showed that, in fact, the impact is not only on maybe the obesity itself, but also on productivity gains. And I think it's important to have that argument, because as we all know, that many of, public health is never the first priority of a country. The first priority of a country is the economic development. So when you can link it with economic development, it's always very important. I think this is interesting because, of course, CLF is doing a lot of work in Baltimore. And they looked into what we called originally food desert, but they have a new term for it. They call it now healthy food priority areas. But similar research was done a couple of years ago also in Cape Town. And you can see that this type of mapping can be extremely useful. And again, to go back to Christine's point, that if you think about communities or cities, it's important to identify, and this kind of mapping can actually help to, for a mayor's office to say, okay, what do I have to do? Can I be more precise with my policies? Talking about Cape Town, I have worked the past 10 years on issues with HIV/AIDS. And I think the world of HIV/AIDS is a very good example how we dealt with actually complex systems. And I think, but it's one of the most successful, I would say, global programs and UN programs, what I've seen so far. And the reason is that we had 11 different UN agencies working on that level. And also the level of people dealing with it was very high. You had the executive directors, including a D2, who was responsible for working on HIV/AIDS and come up with a very, strategies with different points of view, but also had a great driver. In fact, there was treatment and testing. And you could see that if you talk about the future and we want to be effective in a much faster way, yes, a system approach is essential, but when we don't have a driver, which is, some simple solutions which can help us to move forward, I think we will not be successful. And I think the lessons learned from HIV/AIDS are very, very important. That we have to look for solutions which we don't have the full evidence. Because if we don't move fast enough, I think, the world will not react in a proper way. So I also like the fact, again, I come back that, a lot of the domestic work we are doing here is absolutely relevant and should be part of much more a global movement. And I think the work actually Baltimore is doing as being part of the the city of Milan. I was there at that time during the ICN2. But also there's this link. For example, yesterday I couldn't go to that meeting, but there is a link between Baltimore and Rotterdam. And so there's many issues which you can do with cities, because cities are very powerful in the future. They have more money to spend relatively, maybe not Baltimore, but in general cities are much richer than countries are. So you can do a lot more than only focusing on, a typical approach saying, okay, the state is important. Be practical. I think that's a very important solution. If we want to make progress, we can't just be theoretical. And the research needs to focus on those practical solutions at the same time. So in my conclusion, I think it's important to frame obesity in a way that we are open for many different contrasting points of view, because I think there's a lot of contextual differences. But I think it's also important that we are very precise with our terminology. And it's interesting for me to listen to the presentations on all the food systems. It's absolutely clear that that's a method we have to use for the future. At the same time, it's such a complex method that it's very difficult to translate it into simple language. I am very active on Twitter, but if I want to tweet something about a nice food system, nobody understands my tweets. But it is that we need to bridge that, because it's essential that we communicate with people who actually can make a difference, I think, in the future of the problem of obesity. Thank you.
Okay, if we can have, where's Christina? Sit both of you up here for questions. That was fantastic, and I'm going to open it with two questions. Mics will be passed around. My first is, and Martin, this is probably to you, but Christina, feel free to answer it. What are some examples, or what are your thoughts on things the U.S. might be learning from global approach here? And my second question is, how do you put into place the structure of the actual individuals in a community working together, coming from multiple disciplines, multiple points of view, multiple walks of life? So two things, global to domestic, and putting together, because it seems to me that the people piece of this can be quite challenging.
You want to start the global?
Yeah, we'll start. I do it later, because I have a sore throat.
Oh, okay. I'm going to tackle part two, how do you put people together in a community? Many people in the room have done that work before. It's not easy, and I think we all know that there are variables about individuals that make it harder or easier for them to be part of teamwork. So that's something that we can't take lightly. And so first of all, it's different sectors that are represented that you think can tackle the problem. Second of all, it's folks who have the desire to be part of a collaborative process. And a little bit of that is what I described in our group model building work, is giving people a sense of what that means and what it takes. Most likely everyone in the room here is, not only thirsty for knowledge, but willing to roll up their sleeves and hear different points of view and work together. That's not always true if you're working in a community in a really challenging job and you have to put your head down and focus on something, and your budget at your community organization is really small. So I think all those things need to be taken into consideration. But I will say what Ross and I didn't talk about is retrospective modeling we've done with the original Shape Up and Romp and Chomp work from Australia that has informed our community selection. More to come on that with the publications, but we're being really thoughtful and deliberate about what the composition of a coalition could look like that, based on our modeling, would result in accelerating some progress.
Thank you. Some guidance on that ultimately is going to be incredibly useful. Martin.
Yeah, for example, the WIC and SNAP program of the US is a very important example for many of the social security projects in countries, because most of the low and middle income countries cannot copy the model of Europe. It's too expensive. So they look very carefully into what's going on in the US. So research which can be done in places where they have copied, in fact, the US system, but they will try to do it, of course, in a different way to tackle both undernutrition and overnutrition, can be great models to, in fact, be, again, which we could apply for certain neighborhoods or communities in the US. Because it's, certain circumstances are quite different, but there are also quite some commonalities between what I've seen here in the US and in other places, particularly if you look at middle-income countries, more so than, of course, low-income countries. I think it's also quite clear that and again, I go back to HIV/AIDS, because it's interesting to see how, in fact, the HIV/AIDS program has been tackled as a really global program. And the US played a very critical role in that. And a lot of the activities which taken place here in the US also were based on some of the experience were carried out, for example, in Europe. And so I think if we talk about climate change, we talk about obesity, we talk about all these global problems, that these are global problems. And in fact, to isolate the problem saying, oh, it's only a domestic issue, I think is wrong. The communities are different, of course, but there's commonalities and there are differences. And I like the fact that when we had this dinner yesterday, so the discussion about that we need to embrace conflicts, because conflict leads to question, and question leads to better research. And I think ultimately for the school, it's important that we do research which is applicable, to the world. And I think, but that means that you have to say what works and what doesn't work. And I think ideology, what I've seen all over the place in the UN and everywhere, is too often, what people believe. And we have a discussion on vitamin A. There's a lot of people who think that vitamin A deficiency supplementation is not necessary anymore. If you're really, it's ideology, and you have to come back again with facts. So I can see that the balance between facts, but applying it to real situations, but starting to work with things which the evidence is not complete. That's the future. We can't wait until 10 years when something is ready to launch.
Thank you so much. Additional questions? Shariki, who has the microphone? Here we go. And again, please identify yourself.
Thank you. Shariki Kumanyika, University of Pennsylvania and Drexel University. My question follows up on a comment you made last night, Martin, that this idea or the recognition when we have the time to think about it, that there's a whole other set of patterns within, especially within the high-income countries, for indigenous populations of color who've migrated at various points, established migrants and new migrants. And so I'm wondering if, I'm all trying very hard to understand those patterns. If your analysis by the level of agriculture, which is sort of a macro for that country, is there any work yet that helps to use those same patterns with the type of economy and so forth to predict or to explain the fact that in many cases, not all of them, it depends, especially for migrants, on how they were when they came, but the populations of color, including the indigenous populations, are always have more obesity.
Yes. It's a big challenge. In Latin America, you see it a lot. Like indigenous populations are very stunted, and they are very, there's a high level of obesity. The reaction in Rome is quite often they say, because originally we had a very good diet, and because of the very good diet, now we don't have it anymore because of processed food. And I think, again, it's actually the evidence is against that, because if you look historically, they were stunted. So and maybe not obese, but they were stunted. So this comes back to what Bill is saying, the problem of dealing with stunting in many still middle-income countries. At the same time, the prevention of obesity, if you don't have specific actions and you just follow GDP, you will have an increase of obesity and a decrease of stunting. So what you need to think, okay, what's going on, why you have that? Like, it's possible to have a different scenario, but in fact, when people say we know it, I don't believe that we know what actually are the solutions. But if you think about, I think Holland, I take always Holland as a good example, because just before the First World War, the Dutch population was 10 centimeters less, the male population was 10 centimeters less tall than the US population. In the next 40, 50 years, the Dutch population became the tallest in the world. And, but if you look at the BMI at that time in Holland, it was actually much lower than the BMI of the US. So this is really interesting. So you can grow taller and you don't have to get, more fat. But what it is, I think we need to have more granularity to look into those kind of issues. It's possible, but I haven't seen many papers to look into this at all. But maybe Bill knows it better, but I don't think that they exist.
Thank you. Additional questions? Over here. Oh, a couple over here.
Sheila Magay. I'm the new Division Chief of Pediatric Endocrine at Hopkins. And I have an interest clinically and research-wise in pediatric obesity, type 2 diabetes. One of the things that Shariki mentioned is very interesting because I'm hopefully, if we can pass the federal budget, I am about to start an R01 looking at South Asians and cardiometabolic risk because they're at increased risk at lower BMIs, and it's true in migrant populations. Yeah. So yes, there's the issue in South Asia about, and Asia overall, particularly South Asia, there's the issue of the better, higher SES populations having the problem with obesity, but in the migrant communities, it seems to continue no matter where. And there haven't been many studies in adolescents at all in the US, actually there haven't been. And we're trying to study that. It's thought to be due to increased visceral fat, but I wanted to compare a group of South Asians to African Americans to whites because African Americans have less visceral fat, but still increased risk. Mm-hmm. Anyway, but sorry, on a practical level, I wanted to actually bring up how can we increase, this is fantastic, all the speakers, and I'm learning so much about food systems and this whole other way of thinking, because I'm used to thinking about pathophysiology of diabetes and insulin resistance and pediatric obesity. But how do we break the silos, like Christina said, to work together? Because I'm thinking with the Somerville, Shape Up Somerville project, having been in Boston also in the different obesity clinics, I'm just getting started here setting up a type 2 obesity clinic, a type 2 diabetes clinic with nutrition and psychology and hopefully some type of exercise physiology program. But with so much going on in the public health school, it would be great if, for providers to have access, because I have the population right there. If somebody was in the public health school doing a study wanting access to that population, it's right there, and I would love it. But breaking down those silos, there's so many silos just within the children's center versus everywhere else, but between schools, and I didn't know if you had any interaction with the Boston system.
Yeah, so the couple studies I showed, the original Shape Up and then the one it's part of Compact, it's actually called Shape Up Under 5. You may have noticed in that systems map, it said early childhood at the top. Both of those had the entire medical community involved. So they were at the table from the beginning, a representative pediatrician who then was that stakeholder who diffused back. And then I, of course, went to the clinics and the hospital and spoke and engaged them. One reason it's really important is, of course, the medical community is integral to both prevention and treatment, but also communicating with parents in the case of children and monitoring and their data collector. And that leads me to electronic health records. A lot of the studies that I do, the biggest expense is collecting BMI. And if we can set up better systems using electronic health records and collaborate from the beginning, we've got incredible data that we can use more effectively. So I have collaborated with the medical community and all the studies I've done, and I think from a data and then modeling perspective, we can't do it without that. We will never get funding to the level that we can collect those kinds of individual data that we want.
Thank you.
We're going to ask some people are asking a question. Please hold the mic close to your mouth because we're not able to pick it up on the recording.
Next question. Over here. There's one behind you.
Hi, my name is Julie Ralston Aoki, and I am with the Public Health Law Center. So I'm an attorney. We work with communities, with advocates, policymakers around designing laws and policies to promote public health. And so I'm really thinking about this from that lens. And I was just wondering about how do policymakers, particularly like city council members or town council members or county commissioners, fit into this, like the compact study, or and how? I mean, where do you see their role? Are they midstream, upstream, or does it depend? And then I'm wondering how to engage them, these policymakers, more in this kind of systems lens and systems approach, because they're so busy, they're juggling many priorities, they're subject to many different constituencies. So like, how do you translate this for them?
Yeah. Do you want me to take that? Okay. It's a great question, and a lot of my experience in what we're doing now, full disclosure, is sorting all this out. I think, when I think about the way we're talking about bottom up, top down, that we need both approaches, I think about this community level and these key stakeholders and communities being able to bridge that a lot. When, bottom up meaning really like the community at large and all the different groups. So I'd like to think that we can have this layer of, these coalitions or stakeholder groups across the country that are implementing what we want from a national level and also from a local level, listening to their constituents. So the way we've involved policymakers is sometimes at the table as what I'll call the egos, the actual stakeholder group, and sometimes as a first-degree alter or a group of first-degree alters because of the time constraints to be part of something regularly. But I think it's very important. With the original shape-up, we had policy changes at the community level. Fortunately, there was a mayor in place who wanted that, believed in that, and made it happen. Many communities around the country have someone in that position. And now we're doing it one step removed, so staff from the mayor's office is involved. But I think when you think about a diverse coalition and the different representatives that need to be there, it will differ community by community. But if you think of the microsystems in a community, they're pretty similar, one community to the next, meaning someone representing the political system, the medical community, the school system, et cetera. So I think it's really important. And I'll just add to that that they have to work together over a period of time. It's not a meeting and you go back. It's multiple years and a very long-term commitment to make change.
Additional, there are two questions. Oh, Tamar, do you have the mic?
I have the microphone. Does that mean I get the next question?
You have the power then. Go ahead.
Tamar Haspel, Gadfly journalist. Christine, I want to ask about your basic premise, which is that we know what to do. And, I should preface this, excuse me, by saying that I have undoubtedly the fewest advanced degrees of anyone in the room, and so I stand ready to be corrected on this, but I've spent a fair amount of time with the evidence that you are talking about, and my read of it is very different. I read it as emphatically equivocal. And even the slide that you put up about interventions to increase fruit and vegetable consumption, I mean, some of those studies show a slight increase, but some showed a slight decrease, and I wouldn't have concluded from that slide that was an effective intervention. And studies that double SNAP benefits for fruits and vegetables, for example, again, they're pretty much all over the map, although the evidence is more robust for vegetables than for fruits. But again, the slide you put up showed p-values that were not compelling for vegetable increases. And I think, one of the things that Martin said, which is that no country has been able to reverse their obesity epidemic. And, when I asked Bill what intervention he would go with, he went with, sugar and physical activity. And I guess my read is that those are not proven to be effective interventions. And even if they increase fruit and vegetable consumption, we don't know that they decrease obesity because, people have to eat less of something else in order for that to be effective. And I guess, putting all our eggs in these baskets when the evidence to me does not seem to be compelling raises a lot of questions. But I'd be curious what I'm sure other people spend a whole lot of time with this evidence. And I'd be curious to hear what other people think about this.
Sure. Let me be clear. I definitely was misunderstood with what I was trying to present. I was in no way trying to say that those particular studies were groups of studies were definitive or that's the direction we need to move in. Really, I was trying to make the point that some single sector studies have shown results that are positive. On the reviews that I showed, you're absolutely right. Some are positive, some are negative. The ones I showed leaned toward more showing positive than negative, but I was really trying to make the point that those are single sector, they're very small effects, they won't work everywhere, and when I said we know what to do, I was referring more to consensus committee reports that have kind of said collectively we know the direction we need to move in. I think there's a lot of, I'm sorry? Well, I can't definitively answer that. There have been decades of people working on it, and there's been no progress, right? So is it that what we've concluded isn't the right thing, or is it that we haven't implemented it in a systems synergistic way? Or is it that we don't know how to implement it? I don't have the answers to those. I was trying to be provocative and say there's been a lot of work and a lot of peer-reviewed literature that consensus committees have said, here's a direction, here's a framework, here's a list of things we need to do. I don't think we know how to implement them, and I don't think we've done it well. So just to be clear, I don't want to be misunderstood that I was presenting a couple of studies. I was trying to show some innovation in the past couple of years, single sector, a little bit of progress, a little bit of hope, but I personally feel like we haven't done what we need to do. So I just wanted to be clear, yeah.
Can I'd like to... Oh, sorry. Okay. I'd just like to respond on that, because I think what you're saying about evidence, I think is important. We are struggling with stunting in low and middle income countries for a long time. And it's definitely, very important to give the right nutrients, and so lack of good quality complementary food is a big issue. But since, in fact, WHO is focusing a lot now also on overweight and obesity, and so they are very reluctant to work with private sector. We work a lot with private sector with World Food Programme because we wanted high quality products for all the work we did in emergencies. So at the same time, now you have a conflict because there's a lot of negative potential impact on low quality complementary food. At the same time, we need high complementary food. So countries are extremely confused now because they don't know what to do. Again, because there's actually no evidence that complementary food will lead to obesity if it's good quality at all. But people are promoting it. So I think from a scientific perspective and also from a policy perspective, it's very important to be clear, that if you want to tackle both problems, what do you do right? At what age? And what you have to stop. This is why I like what Bill was saying, even when maybe, it's not enough, but focusing on sugar and focusing on exercise are definitely issues. But exercise, again, as you know, Coca-Cola is, are promoting exercise as a solution, and the whole world saying, but that can't be the solution. No, but it's part of the solution. So we need to be much more open-minded and being not ideological, and that's one of your major points, no?
Okay, folks, number one, you're getting feisty out there. Gotta love that. Number two, Martin, I'm so eager to follow up with you during conversations later about your statement. We have to start using things for which the evidence is all in, a statement that sends chilled blood up the spine of some of the researchers I know. Number three, we are collecting index cards with questions and tabletop discussions. If you could get those to either Wendy or Ann over here. And four, we are going to take a break. And how long would you like that break to be? 10 minutes, folks. Come on back in 10. Thank you. Thank you for this panel.